So I'm Ruth Sharrock. I'm a respiratory consultant at the QE in Gateshead, and then I do some regional roles which just keep expanding, as I'm sure most people's role definitions do. But I started out as clinical lead for tobacco for Smoke-Free NHS, and now I'm on the clinical lead for the Lung Pathway Board and for Health Inequalities with the Cancer Alliance, which obviously sits on the same footprint as the ICB. So various hats, and I think the day job of doing respiratory and lung cancer really brings into kind of stark awareness how big an impact health inequalities play in the lives of our patients, and then also how they translate into health care inequalities in the services that we commission and try and provide. And there's some things really stick out, aren't there, in your mind, some people, some patients, some experiences. But my office at the QE used to look out over maternity. I've been evicted now, but that's another story. But it looked out over the maternity entrance, and so when the mums would come outside and smoke at the doors of maternity, I could always smell that, and I'd nip on down the stairs on the fire escape and go out and have a word with the expectant mums and just make sure they'd been offered help and support and all the right products, but generally get chatting to them as well. And I met this girl one day who was 15 years younger than me, and as it happened, she was expecting twins. She'd just had twins, actually, and it wasn't long after I'd had my third, so a baby at home as well, but obviously quite a bit younger than me, and she was smoking, and I said, we offered you help, and she said, oh well, I turned it down because I don't think I'd be able to stop, because everyone in my family smoked. She lived with her grandma who'd got end stage COPD and was housebound. Her mum had died of lung cancer, and she'd already got a 5-year-old at home, and she showed me a picture of the twins, and just thinking that problem, that tobacco dependency, living in poverty, it's so endemic in that community that is the reason that people from that postcode who are dependent on tobacco have a 15-year lesser life expectancy than me, who had a baby in the same maternity unit not many months before. Totally different outcomes for our kids, and that's just not fair, is it? So that's in keeping with the NHS definition. Health inequalities are unfair and avoidable differences in health across the population and between different groups in society. And that include how long you're likely to live, the health conditions you experience, how many years of healthy life you get, and the care that they're able to access. She took up an offer and she did really well. She managed to change to vaping in the end. She couldn't do it with NRT alone, but she changed to vaping, and you just think with, that gives us so much more disposable income, the better experience for young children growing up in the home, 3 young kids there, and obviously if it can pass on to the grandma who's still smoking with end stage COPD, hopefully give her a better quality of life as well. So the National Framework for Health Inequalities, you're probably all aware of, is the core 20+ framework that describes 5 key clinical areas where we should really sort of be giving our heightened focus to ensure that care is equitable, but thinking particularly about the target population of the poorest quintile, the poorest 20% of society, which IMD is just defined as a surrogate of postcode, so it's our poorest communities, and then also sort of specifically thinking about inclusion groups, so that's people in the criminal justice system, the traveller community, people with learning difficulties, those sort of things. And you can see, thankfully, and it wasn't on the first version, but they added it, that smoking cessation, tobacco dependence being a key priority runs across all of them. And obviously, this is the bread and butter of what we all do, but particularly myself with cancer, chronic respiratory disease, smoking cessation, it just makes up a huge proportion of our workload. And when I think, the harms of tobacco, my role, I've got another 2 colleagues deal with lung cancer, just lung cancer. We've got COPD specialists. We've got a whole lung cancer team. We've got a team of respiratory nurses dealing with COPD. Essentially, 75% of the respiratory department is picking up problems from the harm of tobacco at population level. So the scale of the problems is enormous. Forgetting my fancy graphics. And we're disproportionately affected in the northeast. When you look at our levels of deprivation, we all know this. It's reflected in your deep end practice targets. Target practices in the deep end, but also in the trusts within the region that face the biggest problems here. But it's interesting to see that, you know, when you look at all areas within our region, compared to the England average, we're all above that, and Teesside obviously way off the scale. But all of us suffering, and that really translates into the health problems that we're seeing. So when you think about cancer mortality rates, again, everywhere except Northumberland, we're above England average. We're out there. That obviously isn't reflected in the resources that we get. So I think, you know, we need to get stronger and stronger as a region to advocate for why we need more. When we think about lung cancer, we know our prevalence of lung cancer in the northeast is threefold the prevalence of our most affluent areas in England. So you wonder why we get worse outcomes. We're dealing with threefold the number of cases in poor deprived communities who are struggling to access services, essentially because we set up our services in a way that is convenient for us to deliver them, not necessarily in a way that's suitable for patients to access them. So none of us, I don't think, deliberately think that there will be any difference in the way we treat people or in the way they're able to access care. But I think how the very way we go about setting things up, inviting people to come and attend and then deliver things along the journey, we create these problems. So when I've scrutinised the lung cancer pathway, you think about people are being invited for screening for lung cancer, people with symptoms for lung cancer get referred into services, have diagnostic tests, get their treatment. How do health inequalities play amongst all of that? And that was what I was mentioning about our prevalence being much higher, so 50 in the most affluent areas and 160 in the poorest areas. And there's other target groups as well across cancer. So not only is there a huge variance in lung cancer, but your ethnicity affects cancer prevalence, cancer outcomes, more likely to get prostate cancer if you're from a Black heritage, more likely to be diagnosed at a later stage if you get colorectal cancer. We know that we've got poor uptake in breast cancer screening from particular ethnic communities. And we know that people with learning disabilities have higher rates of GI cancer, but are the least likely group to take up on screening. So there's some really, really stark differences in prevalence, outcomes, just unfair and avoidable in many cases. So going back to that graphic I had and the inequalities in our service, we're starting out with that background of different prevalence according to IMD or ethnicity, and then we're thinking about the difference. So where we've got screening programs, that there's differences in uptake of the screening programs, and as with all of our services, there's many factors for that. But we know a lot of them, literacy or communication or language barriers in the way the invites are sent out, cultural perceptions about why people are less inclined to maybe undergo an invasive test or, you know, undress to have a mammogram or a smear. The costs involved with getting to these things, we often put them out in places that are not necessarily easy for people to access. And even when you think you're doing a good job, you know, like lung health screening, we tried to put the vans out near our poorest postcodes, but actually we have the highest uptake when the vans are in the hospital site in Gateshead, because people can book patient transport and get here. When we put it in Asda car park, if you don't happen to live within walking distance or you're too breathless to walk, you can't get there. So I guess it's about not second guessing what the barriers are for people, then not always what you think. And a huge one affecting us in our service is people with carer responsibilities. That's the most common reason for us making reasonable adjustments for clinic times and setups, is because grandparents having guardianship of grandchildren or having a dependent partner, that they just can't leave outside of times they can easily get someone to come in and help look after them. So lots of reasons why inequalities affect people's uptake with screening, and the same, you know, affecting symptomatic assessment appointments. But more than that, people's perception of symptoms and what to do about them. So recognising that an unexplained lump could be a sign of cancer, or coughing up blood being a worrying sign, and there's a variation there across different IMD backgrounds. So those from a more deprived community are more likely to be diagnosed through an emergency route. They've kind of ignored things for a long time. We get our lung cancer different in different trusts across the region, but somewhere between 30 and 40% of our new lung cancer diagnoses come in through an acute and emergency route, and often it's either not recognising that the symptoms were of real concern, or recognising it but not being able to access the sort of triage systems and the routes of entry that we've created. This group always cite the reason, I couldn't get in with my doctor. And when you say, did you try? And try and unpick it with them, it's often they didn't. They just heard once 3 years ago that the GP practices were not seeing people routinely, and haven't really tried since, often not digitally enabled to sort of go on and do online e-requests or e-consults that have helped many a person go through them in clinic. But just a perception that it's going to be hard to get through, and therefore that perceived barrier in itself just puts them off. But again, I guess spending a long time in a telephone queue if you just got a pay-as-you-go phone, or trying to get in around care responsibilities or shift work, all being factors. So we're talking about there being poor symptom perception, barriers to accessing help, and then getting a delayed diagnosis, and that's affecting all parts of your access, your experience, and ultimately has a knock-on impact with your outcome. So then, we've got all of those barriers to sort of even presenting with these symptoms or uptaking screening. But if they get as far as being referred to us, how are we telling them about their appointment? We have text message reminders, yet we know that a very low proportion of our, by surrogate, for instance, our COPD population doing pulmonary rehab, only 15% of them have got an Android phone. There's no point as expecting them to be able to look at stuff on an app, or text message reminders are often not helpful. We send out letters that we just looked at an example of one of the lung screening letters yesterday. It's 4 pages of small A4 print on white paper, looks very bland, lots and lots of talk, and then says, if we don't hear from you within 60 days, I think we'll assume you're not interested. Are we really thinking in terms of health literacy, accessibility, reassurance, in the way that we're communicating with people to not put people off at that first step? And then thinking how they get to you. Some of our places are just notoriously difficult to get to if you're either not on a public transport route or inaccessible. And who do they contact in secondary care? I think we're dreadful at this before people have even kind of come into a clinical service, because you hope by the time you're in, you're aware of who you would need to speak to if you had a problem. But for instance, on the lung cancer pathway, we might be trying to get somebody to go for a CT, maybe some lung function, and come to a clinic appointment. So they could easily have had 3 missed calls from different departments trying to get hold of them to tell them to come for stuff. Ring any one of them and say, I'm sorry, I missed a call. I'm not sure what I'm supposed to be coming for. Well, I'm not clinical. I can't tell you what you're coming for. I can tell you you've got an appointment with this. Fine. But I had another appointment as well. Does this replace it? I don't know. It's not my job. That's not my department. There's no kind of ownership of them to help them navigate our services. So unless you're kind of on the in, or you've got a relative or someone to advocate for you, very difficult to get through. Even as health professionals, I couldn't ring another trust and get through to the person I want to. So how do we expect our patients to? And then the diagnostics are ridiculous, aren't they? As they get more and more specialised, we're sending people all over the shop. So sometimes some types of endobronchial procedure can only be done at North Tees, so specialised. We don't have a room. We're helping to support that service, and good of them to be able to provide it for us. But we haven't really thought holistically. Have we got a really robust way of getting everybody there and back who needs to, who hasn't got their own facilities to do so? PET scans could be at Freeman, could be Middlesbrough, could be South Tyneside car park on a weekends. Our patients don't always have the resource to have that flexibility. We all might, but they certainly don't. And we also kind of discourage assistants to attend a lot of the time. If you're going on booking patient transport, you can't often take somebody with you, even though you might then need somebody to help you navigate things when you get to the other end. We don't screen for additional requirements at the point of offering these appointments. We should do. The services are very much designed about what we're capable of doing and where. A lot of us can't come off sites because we're responsible for a big inpatient base that we're constantly getting called back for, but that means we haven't got services out in the community, which would presumably be preferable for most of our users. And again, the complexity of the tests are just extremely complicated and hard for people to understand. So that's why we don't have comparable outcomes, that you get a worse outcome from your cancer diagnosis according to your postcode. It's not fair. So there's a difference in all tumour groups according to IMD decile that people are in, more pronounced in some than others. So all of those things contributing to different issues with access, with experience, and with outcomes. That all sounds really grim. We're doing things badly. I'm hoping I'll be able to convince us that we can do some things differently and what we're thinking about that in lung. But really, hopefully this can be interactive and you can share your ideas. Obviously, you're often the most powerful advocates for the patients trying to navigate secondary care services, and having a health inequalities hat for cancer at region level on, be really keen to hear what you think we can be doing differently. Obviously, most lung cancer is smoking related, and even at the point of diagnosis, if we can get people to stop smoking at that point, they double their life expectancy. You get an extra 12 months on average, so really powerful. Same with breast cancer recurrence to do with obesity and things. That's even the prevention strategies have a huge role at any point in the disease diagnosis treatment. So anything we can do to embed in our everyday practice at every moment to tackle those issues will have an impact on our communities, and really powerful, and clearly prevention is where we should be channeling our resource. So tobacco encounters I'm really pitching for here. Don't be afraid to bring it up. We know most smokers want to quit, and most of them haven't accessed services. And yet when we make services available to them, give them good enough product, give them reassurance that it might take a while, might take a few attempts, it doesn't matter, just keep on trying. If they've, I say to patients in clinic, we've obviously not done enough to help you in the past. What can I do differently? What have you tried? What worked? What didn't work? What can I recommend you something? And really clear advice on the role of e-cigarettes, because until we've got easy access to cysteine, having lost varenicline, that was our most successful stop smoking product. E-cigarettes are the current one, and they're preferred by patients. So even if it wouldn't be something we would choose for ourselves potentially, certainly not as non-smokers, but if you're advising somebody who's dependent on tobacco to quit, whatever it takes to get them to quit is better for them. So we know that e-cigarettes are vastly safer. They're a very good way of delivering nicotine, and they're so similar in behaviour, hand-mouth action, that patients find them desperately successful in things like the serious mental illness population. They're an invaluable tool to get quit rates, and ultimately that's extending people's lives. So we must be doing whatever it takes to help them to get off cigarettes as soon as we can. And then obesity, which is obviously nowhere near as easy as dealing with tobacco dependency. We've got a very cheap, effective intervention and very clear advice to help with people who are dependent on tobacco, trying to deal with all the commercial determinants of health and the problems with the food landscape and what's available to them in their community, and the food choices that they're making that are often driven by poverty and access to high quality fresh plant-based diets. Are just you feel like you're talking another language. It feels very privileged to be able to afford to eat well at the minute, but these are the kind of messages we can be giving to people. We know alcohol is carcinogenic, so very clear advice asking about alcohol consumption and giving very clear advice about that will contribute to all of our roles in mitigating health inequalities. So I've talked about the kind of the barriers we're creating, or that we're not mitigating, and then trying to think about things we can do. We could collect much better quality data. My holy grail will be that at the point people come into secondary care, that we have a really comprehensive assessment of what their barriers to engaging with care are, and we write them down. And we're hopeless. We've got boxes for ethnicity, they're never filled in. Most people I see who've got any sort of learning disability, it's not already recorded on their record. Even if it's been mentioned on encounters, it's not there. So it wouldn't be easy for me to extract where those patients are, or if I should be able to look and see who's come on a weekend to A&E and gone again, who had additional needs, who might not have engaged with elective care, but we just don't have good enough data quality collection or reporting. So we must get much better at that. And then when we know where this group are, we need to work out how we put our money where our mouth is, that we don't just keep sitting in clinics seeing people who have got the resource to turn up, to get referred and to come and get seen, that we actually think, is it worth us spending afternoons seeing lots of chronic cough, or should we actually try and find all our people who smoking, live in poor postcodes, haven't accessed any other elective healthcare, try and find them and provide some very dedicated case finding, so like outreach into drug and alcohol services. We could change our narrative about where we put our resource and not just keep trying to deliver on the people asking the loudest for it. And as I said, sort of engaging our service users in how we shape our pathways and services, because you can never quite second guess what people might want things to look like, or why they haven't engaged, or what the barriers were, and the solutions might not be the ones that we would think of on their behalf. That we rethink the provision around the users who need it most, not just what's convenient and easy for us to deliver. And in the interim, because we can't build a whole new healthcare service immediately, I think making sure that we put equal priority onto compensating for these things that we know are just having to happen. It wouldn't be easy for me to go and spend half my time doing outreach clinics somewhere, because you needed to be able to respond to clinical emergencies. But we could have navigators ringing people, making sure they know about their appointment, making sure that they know how to get here. If they can't, booking them transport to get here, speaking to a carer or a relative to help facilitate them getting here. We can do all those things, and that's what we're trying to build in, certainly into our lung cancer pathways. Need to do it more widely. So if you look at one tumour group, for an example, in lung, with a health inequalities lens, we've bid for and received some funds to do some really targeted work looking at our non-engagers in our screening population. Why haven't they taken it up? What can we do to mitigate that? And sometimes the answers are really simple. I had a really good meeting with some GPs in Northumberland a few weeks ago, and some of those practices have done this themselves already, just reaching out to people who haven't taken up the invite, and sometimes as simple as somebody explaining to them what's involved on the phone and what the benefits are, and they most of them agreed to sign up and have it. So it was a very simple, didn't respond to a very wordy, lengthy invite letter, quite happy to respond to a phone call. So there's some quick fixes, I think. I think we need to think about our routes into our service. It's not, a GP 2-week wait referral in brings us one cohort of patients, yet we know that all the people who, the 30 to 40% who present as an emergency, is a totally different group. And even if you correct them for stage at presentation, the group who came in as an emergency do worse. So why? Where were they going? If they didn't go and see their GP and get referred in, what were they doing? And anecdotally, it's often things like they might have rung social services for a bit more help at home, or they might have reached out to citizens' advice about their benefits because they couldn't do their kind of ad hoc cash in hand job anymore because they're breathless and they're coughing up blood, trying to think about other ways to keep the finances ticking over. Their primary concern was not getting an answer to their health problem. It was to be able to carry on living, doing the day-to-day. So if they're going somewhere else, how can we open that up as a door to get them in? And that's what we're doing with our drug and alcohol team. They're going to do a screening question for respiratory symptoms, and we'll open up our referral doors to them to be able to send us people straight in, that we don't put more barriers in, that we just advise them to go and see their GP if they're ticking red flag boxes. I don't care who tells me about it, they just need to get to us. Strongly trying to encourage all colleagues to really consider our DNAs. I've, since being a consultant, taken it very seriously. If someone was on my list as supposed to become, that they're my responsibility, I ring them, ring their relatives, try and find out why someone didn't attend. And it is never ever the case that they just didn't want to come. They might be terrified, they might have mental health problems, they might not have any money, they might be a carer. Nobody's ever said, oh, I didn't want that appointment, I didn't. And you can make some reasonable adjustments and get them there. The last one we had with a cancer of unknown primary was a girl with autism who didn't come in case she knew she'd meet a lot of people, but especially men, really didn't want to be in any environment where she might be undressed or examined with any male colleagues there. But we managed to set up CT with only female colleagues one evening and got her in and had a scan. So anything can be done. We just need to interrogate what the need of the service users is more carefully. We should be using our diagnostic journey time, and I'm talking specifically about lung, but there'll be lots of other cases where this is relevant, to really put right everything that's happened. So obviously stop smoking is the most important one, but optimizing diet, fitness, mental health, putting them in touch with all the services, managing comorbidity, so that by the time we get to a confirmed diagnosis, we're in a position where more people are eligible for a radical treatment. There's so many patients, you get them through all this, eventually you find that they've got an early stage lung cancer, but actually they're not fit enough to have the treatment at the end, can't have surgery, and that's just really sad. And it's often because they've kind of got such low life expectations, they've just not really done very much since COVID, stayed in the house, not really gone out, and never got back to it when the rest of us did. So sometimes 4 weeks of quite targeted physio, especially if they've got someone to advocate for them at home, like making them get out and do a bit more, you come back with a different person. And it's regularly people will come back after that sort of intervention and say, I feel better now than I've ever done, and you've just told me I've got lung cancer. You know, you can really turn things around for people. It's never too late to make some of those inroads. We need to maximise our use of healthcare resource in people who make things better for this group. So we're utilising navigators to try and reach out to everybody, map out their need and make sure they get to their appointments and can do, or that the appointments are adjusted to suit them, and care coordinators later on in the pathway. But those roles are quite new concept, but they're just as important. They're probably more important if you ask the patients. Patients come to my 2-week wait clinic and like, where's Jane? Far rather talk to them than the clinical specialists. They're kind of navigating the system on behalf of the patients. We should map out digital exclusion, and we need to speak really loudly about this, because all the kind of pressures and incentives from above are who's got a new exciting new digital technology. And you know, it's just not, if only 15% of your patient cohort have got an Android phone, we're widening the gap if we put all our money there. Certainly not that we should turn it away, and it would, there's plenty of digital solutions that would help in terms of how we manage stuff in healthcare, but it can't replace clinical care for the patient. And having patient representation in our decision-making processes, and I'm trying really hard to advocate for that and get them there and get them to the forums and hear their voice, even when it's a difficult one to hear, and it often is. But it really shines a light on what we're doing, makes us more accountable. And I think we're sometimes in danger of, there's obviously variation across the region. Often the resource ends up going to the services that have got most headspace to hear about opportunities, fill out bids, put in proposals, come up with, you know, pilot projects and seek funding for them. And it's actually, we need to do the same, that we should be looking out for the teams we don't hear from, that we know get left out of all this, and be very proactive in reaching out for them for delivering an opportunity in the way we commission our services. This was really interesting. This was colorectal screening uptake, and the difference between people from the so on the left, the poorest deciles, so like IMD 1 and 2, the uptake is lowest, and yet the red line is the positivity rate of the test. So you find most of your cancers are found in the group that are least likely to take part in the test, and sort of really scrutinising what we're doing and how we're engaging. And that was just an infographic showing the variance in survival for all the different tumour groups by their geography. So I guess the questions for us all to consider are, where are health inequalities impacting most on our practice? We might see it, or we might not see it because they don't come. Our drug and alcohol service is a good example of that. People with profound respiratory disease just don't access secondary care, or if they do, they might come in a crisis on a weekend and go before any of us have come back to work on Monday. And we haven't built in mechanisms for reaching out to them and doing something not in the heat of the crisis, something planned, engaged, defined by them. So what can you see? Think about what bits you can't see. You know, for me, starting as a consultant, that was the DNAs, ringing them and finding out why they didn't come, and it just opens your eyes to the unmet need. And you'll obviously all know your places better than me, and your pathways and processes. You know, where are people slipping through the net, and where are these many factors, the learning disabilities, neurodivergence, rural, coastal, excluded communities, traveller communities, deprivation, low health literacy, all the groups we might be leaving behind. But really, I think what's probably more important is if we discuss it and you share your experience of, you know, you advocating on behalf of your patients, the screening projects that you're involved in, what you see and what more we could be doing to advocate on their behalf.